So the 3D printing is not new at all. The first report is 1981 from Japan, Hideo Kotama. But this is purely academical exploration. But a few years later, Chuck Howe developed a commercially available 3D printing equipment. So usually it used to be called as the additive manufacturing, but after that, the rapid prototyping was the very common terminology for that. And then the people begin to make a gun out of 3D printing machine, and then mass media cover this as 3D printing. And then almost always now that the 3D printing is a more generic term to talk about this additive manufacturing, rapid prototyping. What is additive manufacturing? It is in contrast to subtractive manufacturing, which means that if you make a kind of sculpture, you are given a piece of wood or stone and you subtract piece by piece until you have this product. However, with the computer-based information, you can make any object building layer by layer until you have the final object like this. That is why it is called additive manufacturing technology. So what I want to do in the next 12 minutes is that how we make the heart models and utility in medicine of congenital heart disease and then future direction. There are multiple technologies available. I don't want to go over. There's some are powder-based, some are fluid-based, some make flexible models, some make hard model. So the application we do is using the Inkjet technology. What you have is that there are two platforms here. One platform is container of powder. The other is that actually the printing platform. What it is that this roller pushes the powder to the other side, and there is a very thin layer of powder. Powder is on the powder, Inkjet, exactly the same cartridge we use it for the Inkjet, has the super glue instead of Inkjet, colored super glue, and then make a drawing according to the digital information. And then once that is the fixed, and then this piston goes down, and then there is another layer laid, and then there is another drawing, layer by layer, until you have final product. You can use the fluid base. This is more sophisticated. Here that the object can stay there because there is the power in the adjacent space. So powder is a supporting material. However, if you use the fluid, you need to have a supporting material too. So this Inkjet, called Polyjet, sprays the printing material as well as supporting material, and then the materials are cured by ultraviolet light. So this is the machine, and then this is the model with the powder, pretty good. You have a color, but however, this has limited for the flexibility. It's a hard model, basically. So however, using the photopolymer resin, you can make a flexible model like this, which is more plausible for cardiac application. So what you do is that imaging right, and then call this very similar to what you do in CT and MR, segmentation for volume rendered imaging. And then that is the DICOM data, which is our imaging, the file format, and that should be converted to STL or other printing friendly computer language, and then that is fed to the printing machine and you have print. So for instance, this is how we segment the cavity, in this case with tetralogy fellow, as we do in the day-to-day practice in the workstation. And then the valve is really very difficult to make, but the idea is that at least we want to have where the mitral valve and tricuspid valve, aortic valve, the inserts to the myocardium, and then this is the really graphic representation of valve attachment. And then here we give a little bit of thickness to make a kind of pseudo-annuli representation in the model. So this is how it is in the computer. This is a cavity, and you have the valve attachment there, and then we make the print like this. So this is a cavity model, and then it's completely same as the the angiograms. This is not what surgeons want to have. So what they do is that they make a cover out of the cast. It's the approximately 1.5 to 2 millimeter cover outside the cavity and remove the inside and then rotate it, and then it's just to trim out and like this, and then open that, and then this is the inside of the right ventricle showing the tricuspid valve, aortic valve, VSD here, aortic septum and pulmonary valve, and then print out, okay? So this we call that endocardial surface representation. So this will give you opportunity to look at the surgical anatomy very well. So the other is that that is for surgical planning and the observation. But however, if you want to do the practice, so usually the surgeons do not make the right ventriculotomy. So open the right atrium only like this. So this will give the root, sorry, where the surgeons will going to look at the right ventricular side of the tetralogy fellow, and then to practice that, the motor should stay on the flat surface. So we make the platform to have this motor fixed on the flat surface, and then this is all graphically designed platform to have the motor to stay. So this is a final print. So you have the motor like this, and then this is for the surgical practice. Okay. Ideally, it is better to have your all myocardium segmented. Yes, you can do. The problem is that it's not easy and very time consuming. And then the current material is not as good as the human myocardium. It's too stiff, and then it's heavy. And then also that it costs the material, you need more material than the way how we do in the previous slide, so high cost. So we just do endocardial surface anatomy. Applicable imaging modality is CT and MR, mostly the angiogram. ECG-gated is better. Breath-held study or respiration navigated study is far better because those have a motionless picture. 3D ultrasound can be used. Rotational CT angiography also can be used. So this is the ECG-gated CT scan-based model, and this is the respiration navigated ECG-gated MR angiogram-based one. So both have a little bit of advantages and disadvantages, but in our institution we prefer MR, but most of other institutions they prefer to do ECG-gated CT scan. So ultrasound is ideal, but the problem is that although it is inexpensive image data and then best for the valves, but the spatial resolution is limited and there is a lot of artifact. This is the model we made from the 3D ultrasound, and then I don't think you like this. So we use that for the clinical service, for the surgery, planning, and practice, and then it gives some idea about the intervention. And then the education is another good application in terms of patient and family education, and then morphology sessions as we did 2 days ago, and do the practice surgery. And then also you can do the imaging simulation. If you make the motor and then immerse into the water, you can do the ultrasound or MRI scan or CT scan. Okay. Why 3D printing for surgery? So congenital heart disease is very common. However, individual lesions are few. So because there's wide variation. So individual variations are often rare, and very often the anatomy is complex, and then infant heart is very small. So this is what we do. Usually that we do echocardiogram, and then in the conference we discuss and then present the cases. The problem is that when you have a complex anatomy, there is significant gap of understanding between ourselves and surgeons. And then what if we make the motors like this and then provide this to the surgeon? We don't have to even discuss. The surgeon knows exactly what to do. And then the other is that if you make the motors like this, you can do the practice surgery before doing the actual surgery. And on top of that, if you accumulate the cases, and then you can use these motors for hands-on surgical training for the trainees and young surgeons. So I'm very passionate on the 3D printing. Why? If you can save 5 patients in a year who are supposed to do Fontaine operation, but you did biventricular repair, that actually justifies the money you spent already. So the reason being that if you have a single ventricular repair, you have terrible abdomen like this, liver cirrhosis, and the mesenteric edema causing protein losing enteropathy for life. Okay. So in Hospital for Sick Children in Toronto, we began to use 3D printing in 2009. This is a list of cases, all complex cases. Usual cases we don't do, but most of the cases are basically a double aortic right ventricle, because the surgeons often not feeling comfortable in understanding the complexity of intracardiac anatomy, and then decision for univentricular to biventricular repair is very important. Okay, so this is another case that so-called crisscross heart. We spent here 15 minutes in presenting the case in the surgical conference, but the surgeon decided, I still don't understand, and June, would you like to make the motors? So this is a motor from the MR angiogram. You see the superior vena cava, inferior vena cava, right atrium. This is the left ventricle, right atrium to left ventricle, and then left atrium, appendage here, left atrium to right ventricle, giving rise to the aorta, pulmonary trunk behind. This is the infundibular septum. So this is a so-called crisscross heart in the presence of congenitally corrected transposition. So this is a usual congenitally corrected transposition. What happens in this case is that the heart is twisted in counterclockwise, so right ventricle moves up and the left ventricle moves down, and this anatomy is very, very simply can be understood. So inside is the anatomy is like this. So you have your left atrium, mitral valve, right ventricle, aorta, and then pulmonary trunk behind. So if I stop there, so the question is that this is mitral valve, right ventricle to aorta, and this is pulmonary trunk. Whether VSD is this the VSD or is this the VSD? So it depends on how you define the VSD, but however, bottom line is that if we have a motor like this, I pass the plastic bar into there, and then clearly bar has this free access to the pulmonary trunk, and then this can be regarded as surgical VSD, and then you can close this way. So when you have your motors in your hand like this kind of understanding and the surgical planning is very, very simple. So we talked about the pulmonary regurgitation in the previous section, and then you put the melody valve or venous valve like this. There are a few instances of having problem. So simply because that you have a very, very variable RVOT morphology, and then some cardiologists do want to have these motors before doing the procedure. So this is the example. So we do the endodiastolic imaging and endosystolic imaging, and then make the motors like this, and then put the motors into that the motor, the melody valve, like this into the RVOT, and then test whether it fits nicely or not. I don't think it is the common application, but here you can consider this if you have problem. Okay. So 3D printing accumulation education is important. So we are studying the cardiac morphology in this meeting, mostly rely on the pathology specimen. The problem is that the pathology specimens are from autopsy or transplantation. Of course, they are not representing the whole spectrum of the abnormalities, and then of course there's a limited availability, wet and smelly, and limited access. What if you have your all motors from general population having congenital heart disease? You have full spectrum. Okay? Although the problem is that this fine detail would not be able to be represented here, but the overview about the wider variation will be more easily applicable in the teaching of morphology of congenital heart disease. The other is that there is increasing the public awareness of having specimen in the pathology lab is a human right issue. So therefore, the specimen will not be available with time goes by. Okay. So that's how that we developed the program to develop educational material. These are the two products we have generated. One is that one full set of double out right ventricle, and the other is that crisscross on topsy-turvy heart and superinferior ventricles together. So with that in as a teaching tool, this is example of one case. You have a Castor model, and then ventricular septal model and basal model. These three will give you a pretty good understanding of congenital heart disease morphology. And using that, we organize the morphology sessions like this. I really like the smile of this gentleman here, senior cardiologist from Norway. And then they really liked it. So this is another one that this is the Tom Sprays, the head of cardiac surgery in Philadelphia Children's Hospital, teaching the surgical morphology of double out right ventricle using the models we've made. Okay? So he's really explaining that what's going on here from the surgeon's point of view. Okay? And then lastly, the most importantly, practice surgery program. We named that hands-on surgical training host program. So we give you a setting of table like this, and then they are sitting on the table doing the procedure. And then the first is that this model is given, and then they plaster that model on the table, and they do the surgery here. So this is a hypoplastic left heart syndrome. Incision is made into the 1.5 millimeter ascending aorta, going down all the way to the coronary ostium. And then next is that putting the patch in the inside the aortic arch. Okay? And then finally, the node operation is done. Okay? So seeing all of this, I thought to myself, you surgeons don't practice your procedure on me. So you practice your surgery on the 3 different models first. Okay. So this is the first the course we supported in the American Association of Thoracic Surgery last year. 60 surgeons got together in the same room, and then we provided 120 models to do the practice. And that is one. And then this the last December we did another course here, and then last January we did another course in Toronto. So, and then at the end of the session, the surgeons discuss what the attendees did on the surgical model and whether the procedure was appropriate or there is any issue. So it's really a great opportunity for the young surgeons to have this kind of exposure. So far that we organized 3, and then we are planning to do another one. And then this is the audience response to all these 3 conferences we provided. So here is the answers from the attendees. Models provided necessary information on pathology. So strongly agreed in more than 70%, agreed in approximately most of the other people. Quality of model for surgical simulation is excellent or good. And then, however, consistency and elasticity of the model material similar to human myocardium, most of the people think it is different. Of course it is different. And then a little bit similar or very similar and very different, very wide distribution. However, most of the people think a model material was acceptable for surgical simulation, highly acceptable, at least manageable, which means that the models can be easily used for the surgical practice. Okay. Finally, that the valve tissue is very difficult to represent. In the hands-on experience, what if I make a fake model, the valve, and then put that into the model and then they print together, and then at least that the valve can be represented for the fake surgery in the model. So this is the first graphic design of the cardiac valves, and then that is the put into the graphic model here and then printed. You see that the normal left atrium, mitral valve, anterior leaflet, and posterior leaflet, and then this is what it is. This is a graphic, and this is open the left ventricle, anterior leaflet of the mitral valve, coda tendinae coming down, and anterolateral papillary muscle and posterior medial papillary muscle. So it's just the beginning, and we try to make this representation to the surgical simulation heart case, not clinical case. I don't want to mislead the surgeon. So to conclude, 3D printing is, I would dare to say, is an established technology now, and then can be applied for clinical service and education. And in the future, you can make the tailor-made implants using this technology. Thank you very much for your attention. Okay, a good image saves 1,000 words, a good model saves 1,000 images, and then a good model saves 1,000,000 words.